All right, so this is chapter 13, psychological disorders. For those of you who are wondering why we're at chapter 13, we're skipping ahead a little bit, so we're going to skip chapters 9 through 12, and then we'll pick those up again later on in the semester. So this chapter is going to deal with psychological disorders, but before we get into the individual disorders themselves, there's a couple of definitions you're going to want to know. The first one's going to be psychopathology. So, the book's definition is the scientific study of the origin, symptoms, and development of psychological disorders. Really, this is the study of mental illness. And psychopathologists look at a couple of things. So, they do look at definitely symptoms. So, what kind of symptoms can we expect if somebody's diagnosed with a certain disorder? What are some of the behaviors that are fairly common with those disorders? They also look at the causes. And with all of these disorders that we're going to look at in this chapter, they're very complex. So that it's not as simple as saying, well, all right, so this person has depression. Here's the cause of depression. Causes can be there. There's a bunch of different causes for all of these disorders. It can be genetics. It can be just the biology. It can be a social thing. Some disorders, I mean, the cause is purely psychological. So that's really what they look at. They also look at what the course and the development of each disorder is. So once somebody's diagnosed with this disorder, what can we expect? As far as if it's left untreated versus if it's left treated. Some people, for whatever reason, have a disorder and it clears up or goes away on its own, and for other people, unfortunately, it becomes a lifelong struggle, and they just struggle with that disorder. Um, so the other thing that psychopathology is really focused on as well is not just identifying, but also how do we treat, what are different strategies for these disorders. So in a way, psychopathology is all about exploring problems that are related to mental health. um, how to understand them, how to classify them, how to fix them. Because of this, the topic of psychopathology extends from really research, really early on, trying to identify the disorders, all the way to the treatment. And it covers every step in between, really. And so, the better we can understand why a mental disorder develops, the easier it's going to be to find some form of a treatment or effective treatment for them. Now, psychological disorders in themselves, and really the book definition of this is that they're patterns of behavioral or psychological symptoms. Really, they're health conditions that involve either changes in emotion, thinking, or even behavior. And the way that they're identified or classified, there's a couple of ways. Really, we're talking about abnormal behavior. Whenever we're talking about psychological disorders, it's abnormal behavior. Now, before we move any further from there, we gotta first figure out, well, what's considered abnormal or normal behavior, and who actually defines that, because there really isn't such a thing as normal. Normal doesn't really exist. Nobody out there is 100% completely normal. We all have little weird little things, or abnormal things that we all do that, if honestly, if anybody really found out about, we'd all be locked up for a really long time. But um, how do psychologists figure out whether or not something falls under a psychological disorder or is just normal behavior? So there's three kind of ways of trying to identify them. Psychologists first started out by saying, all right, so if this pattern of behaviors or these symptoms cause significant personal distress, then let's say it's a psychological disorder. So if the individual is suffering, if the individual feels distressed, or they're stressed out about it, or they're constantly worried about what's going on, and there's a pretty good chance that it's a psychological disorder. But there's a problem with that approach. What if the person doesn't actually know they have a problem? Or what if the person doesn't feel like it's an issue and they actually like the behaviors that are associated with that? So, for instance, let's use substance abuse as an example. What if a person who drinks a bottle of whiskey every night, right, or every day throughout the day, but they enjoy doing that and they like doing that? They're probably not going to go out and seek treatment for it. So, because it's not really causing this person any significant distress that we know of. So psychologists took it a step further, and they said if these behaviors or these symptoms impair the function in one or more areas of life. So if one or more important areas of function, which might be like work, school, family, relationships, if this kind of behavior impairs that function of that individual, then okay, we're probably dealing with a psychological disorder. So if this individual, for instance, can't hold a steady job because they're constantly drinking or they're drunk on the job, or family wise, like let's say they forget to pick up their kids from school because they're drunk, then we're probably talking about a psychological disorder. But again, there's another problem. If this person, let's say, is a really high functioning alcoholic, does well at work, um, doesn't have any family, so nobody really complains, and he doesn't want family or doesn't want friendships or whatever. Again, now this isn't something that's causing this person to stress, and it's not really impairing their function. We can't really say that it's a psychological disorder. So then psychologists took it a step further and said if these behaviors or these symptoms are a serious departure from what society or culture considers normal, then it can still be characterized as a psychological disorder. And so here's that important part: the distinction between how we know something is normal or abnormal usually just comes down to the society or the culture that we live in. So you definitely want to either put a star in your notes on this or highlight this part or just remember this. This is definitely a test question. Um, who tells us or who defines what's considered normal or abnormal? That's going to come down to the society that we live in. Now, that's abnormal versus normal, but as far as psychological disorders are concerned, most of that's going to come out of something called the DSM-5. So the DSM-5 that stands for Diagnostic and Statistical Manual of Mental Disorders. The number five just tells us that it's in its fifth version. And so this is a book. It's a pretty thick book that's used by healthcare professionals, psychologists, psychiatrists, in the U.S. primarily, but even across much of the world as well. And it's really the authoritative guide to diagnosing and classifying mental disorders. So what this book contains is it's going to describe, so descriptions. It contains some of the symptoms, and then just other criteria that are required for an individual to be diagnosed with a certain disorder. Currently, it describes more than 260 specific psychological disorders, so it lists all of the known disorders or all of the classified disorders. So that'll be things like depression, PTSD, anxiety disorders, eating disorders. I mean, schizophrenia, any psychological disorder that you can think of. This book is going to list them and then also tell you specifics. Like it's almost like a little checklist that a person basically has to check off a number of symptoms before they can really be diagnosed with a certain disorder. Now that's great, right? And so that should make diagnosing really, really easy, and nobody should ever be misdiagnosed. And really, anybody should be able just to go out, pick up this book, and we wouldn't even need psychiatrists or psychologists anymore. But in reality, there's some issues with the DSM-5 and diagnosing in general. So what I put up on this slide here is two completely different disorders, and I've listed some of their symptoms. So symptoms of disorder one, and this will be depression, is lack of sleep, irritability, lack of concentration, and diminished interests. All right, symptoms of disorder two, lack of sleep, irritability, lack of concentration, diminished interest, right? Same exact list of symptoms, but this time it's PTSD. So two drastically different disorders, two disorders that are going to be treated very differently, but can look very much the same as far as symptoms go. And really, that's one of the main issues with just going strictly by what the DSM-5 says and just going strictly by trying to match up symptoms. And so this happens all the time. People get misdiagnosed all the time. I've had it in my own experience with clients and patients where they've gone years under a diagnosis of depression, receiving treatment for depression, but never getting better. And then once they really sit down with somebody like a clinician or they sit down with a therapist over a longer period of time, some of that the underlying stuff comes out, and people figure out, oh, this isn't depression. Of course, it's not going to work because it's post traumatic stress. But that's really the main issue with just relying on the DSM-5 or just relying on symptoms. Period. All right, let's get into the different disorders. Now, we're not going to cover every single disorder because, like we said, there was something over 260 of them. We'll be here for the rest of the semester if we're doing that. So we're only going to be covering some of the main ones, and really, I'm going to spend maybe more time on some of the bigger ones, and then just kind of skim over some of the lesser known ones. But really, the goal for all of you is just to be able to kind of identify these different disorders based on some of the characteristics that I'm going to go over with you guys. So on this next test, a lot of the questions are going to be little scenarios of individuals, and then you're going to have to be able to identify what disorder this individual has based on that scenario. There's also going to be a homework assignment for this week where I'm going to give you guys a couple of these scenarios and you just have to try to figure out what disorder it is. If you can do that based on your notes and your understanding, you're going to have to do the same thing on the exam, so you should be fine if you do well on this worksheet. So before we get into the anxiety disorders, let's just talk a little bit about what anxiety is. So anxiety in itself, we've all have felt it at some point. It's that unpleasant emotional state that's characterized by physical arousals, feelings of tension, apprehension, and worry. So we've all felt anxiety at some point, and that's pretty normal. So whether it's, anxiety before a big test, or anxiety before an interview, or anxiety before, a date, or whatever it might be, we've all felt anxiety, right? I think most of us are feeling some anxiety right now over this entire situation. Anxiety in itself, that's not a bad thing. It's not a disorder in that sense when we're just talking about normal anxiety. Normal anxiety, biologically and even from an evolutionary standpoint, some people argue is actually pretty important for us as a species, important for us to survive. Anxiety kind of gets us motivated. Anxiety gets us to act, right? It gets us to notice the thing that's causing us anxiety and gets us motivated to either move away from it or solve whatever it is that's causing us some anxiety. So in that sense, anxiety in itself is not a bad thing. But where normal anxiety and then anxiety disorders, where those kind of differentiate themselves, is once that anxiety becomes really excessive and unreasonable. At that point, it's no longer that daily hassle kind of anxiety, and it's really more of an anxiety disorder, something that is really causing an individual some distress. Now, one of the most common anxiety disorders out there is something called generalized anxiety disorder, or GAD. This is characterized by excessive, persistent, and unreasonable worry about a number of different things. So this is anxiety that's general, right? It's generalized. It's anxiety about everything. Now, this disorder comes in different, it's kind of on a spectrum where some people have it pretty mildly, and then some other people have it very severely. But most of the time, we're talking about everything is going to cause this individual some anxiety. So, for instance, a person with this disorder might wake up in the morning, they're going to be worried about, am I going to be late for work? Then they get into their car, they're driving to work, they're going to be worried about, I'm going to get a flat tire, I'm not going to make it to work. They'll be worried about going through intersections that maybe someone's going to hit them and they'll die. They'll get to work, they're going to be worried about whether or not they're doing a good enough job to keep their work or keep their job. Then once they leave work, they're going to be in their car again, worried about everybody else, worried about whether or not somebody's going to hit them in the intersection. Once they get home, they're going to be worried about, am I going to wake up early enough tomorrow to make it back to work? So they set themselves 10 alarms. So it's this constant worry about everything. Everything is going to cause them some anxiety, some distress. And this can be really debilitating to people. I mean, I had a client really early on who had generalized anxiety disorder, and it was a challenge just getting him out of the house. I mean, he really thought everything was going to kill him, that he would die. And as soon as he left the home, that he would spot all of these different things in the environment that he felt were threatening and could kill him. And so, I was going to point out this unreasonable anxiety that he had. And I told him, well, hey, you can die at home as well, right? and that really didn't go over well. I mean, I never saw him again. He's, probably bubble wrapped somewhere, sitting in the closet. So that obviously didn't work. But that's how debilitating this generalized anxiety can be. Now, one of the things that can come out of generalized anxiety disorder is called a panic disorder. And so, a panic disorder is really a disorder of just having multiple panic attacks. Now, having panic attacks in and of themselves is not qualified for a disorder. It's actually a fairly common thing. It's not unheard of that individuals will have panic attacks throughout their lifetime. Where it becomes a disorder is when these panic attacks become a lot more frequent. So, if somebody's having multiple panic attacks a month, multiple panic attacks a week, some people with really severe panic disorder have multiple panic attacks in the same day. And panic attacks are these sudden episodes of extreme anxiety that rapidly accelerate in intensity. And for anybody who's ever had a panic attack, you probably know that these are no fun whatsoever. They're really intense, shortness of breath, really a quick onset of really intense fear, hearts pounding. This little picture here in the middle of the slide kind of pinpoints some of the things that happen during a panic attack. So they're definitely not fun. A lot of people end up in the emergency room because they feel like they're having a heart attack, and then they do all the different tests. They test the heart out, and they say, no, your heart's actually good. You're probably having a panic attack. Now, one of the things that compounds the issue of panic attacks and panic disorder is actually another disorder that can come out of having a panic attack, which is called agoraphobia. Agoraphobia is oftentimes defined as the fear of open or crowded spaces, and this is your book's definition as well. And there's an issue with this definition because it doesn't really give us the entire story. What agoraphobia really is, it's an anxiety disorder that entails a bunch of different fears, and they're all based on the need to escape from a situation. So agoraphobia, and how they're tied into panic attacks or panic disorders. An individual will have a panic attack, or they'll have developed panic disorder, and they'll start to worry. They'll start to worry about, what if I have a panic attack in public? And there's kind of two ways that this fear or this worry kind of manifests itself. One is a fear of embarrassment. Like, wouldn't that be really embarrassing if I was in a classroom or at work or in a really crowded or public place and I had a panic attack? Oh my God, that would be so embarrassing. The second way that fear manifests itself is, what if I'm in a situation, I'm having a panic attack, there's people all around me and nobody notices or nobody knows how to help me out, or there's so many people that I can't get out of this situation. So what ends up happening is that fear becomes so intense that these people start to isolate, and they actually will either isolate themselves in their homes. They'll never leave the home, or if they do leave their homes, it's with somebody else that knows about their condition or knows how to get them help or get them out of it. What they'll do is they'll start to avoid really crowded places. So they'll they any place that's really crowded, any place that's really enclosed really tightly, where people are packed in together, or even just really big wide open spaces. And basically, it's any situation. They're going to avoid any situation where, if they feel a panic attack is coming on, it'll be really hard for them to get out of that situation. They'll just completely avoid it, or the only way they'll go there is if there's somebody there that knows about their condition and can help them get out. So agoraphobia can be very problematic in the sense that people will stop doing anything really. They'll isolate and just basically stay at home all day long, kind of like what we're all doing right now, right? So we're all getting a firsthand experience of what it might be like to have agoraphobia. So this ties into the next set of disorders, which are our specific phobias. Now, specific phobias are excessive, intense, and irrational fears of specific objects. So this kind of differs from generalized anxiety, where generalized anxiety was general, where everything was causing some anxiety. Specific phobias, there's a specific object or a situation or a thing. So there's one thing that's going to cause this person a tremendous amount of fear, a tremendous amount of anxiety. Probably the most common one that most of you guys have probably heard of is arachnophobia. That's the fear of spiders. And this isn't just normal fear. I think there's a distinction between that. So, normal fear is what we all kind of feel normally, right? So, for instance, most of us are not going to be too excited about having a spider crawling on our arm. But with a phobia, it's not just those normal situations. Phobias can get really intense to the point where just thinking about a spider or somebody mentioning the word spider will trigger that fear or anxiety. Or watching a movie and there's a spider on the screen in the movie or in that scene, people will really freak out. They'll start feeling really intense fear. They'll start feeling anxiety. So it's again, it's very irrational. And that's the specific phobia is really the basis of it all. And there's a bunch out there. Animal phobias tend to be the most common. So those are, these irrational fears of dogs, snakes, insects, mice. It's pretty common. It can also be situational. So just irrational fear of certain situations. Flying is one of those. Going over bridges or tunnels, pretty common. The fear of being in elevators, that falls under specific phobias. It can also just be, there's natural environmental phobias out there. So people who have phobias of storms, of heights, like that fear of heights, that falls under the category of phobias. There's hundreds of them out there. We're not going to go through all of them. Just understand what specific phobia is. Now, one that we are going to spend some time on is social anxiety. Now, social anxiety or social phobia is very common in your population, which is the college student population. And if you think about it, there's probably a bunch of you right now that would much rather catch coronavirus than have to give a presentation in front of a class or do some kind of public speaking, right? Now, I don't know. I probably not. It's probably not that bad. But a lot of people just absolutely hate the fact or hate just even thinking about having to give some kind of a presentation in front of class or do some sort of public speaking. They feel anxious. I've had students who've given presentations and they start trembling and sweating and shaking, and all of a sudden they start rambling and nothing makes sense anymore. That's what social anxiety is, and that's a social phobia, and it's a very common one in college students. So the core of social phobia is really an irrational fear. Again, remember, all phobias are tied to some irrational fear. This one is tied to the fear of being embarrassed, judged, or critically evaluated by others. And so that's the main issue there. Most people who suffer from social anxiety or social phobia, it's because they have this overbearing fear that other people are judging them, other people are critically evaluating them, which stops a lot of people from doing things that they really want to do or things that they could excel at just because they're worried that other people are going to look at them weird, other people are going to judge them in a negative way, or they're going to feel embarrassed. Now, the next anxiety based disorder we're going to talk about is post traumatic stress disorder or PTSD. And I'm probably not going to do this any justice because I'm only going to spend a little bit of time talking about the cause and then some of the symptoms. But that being said, I have a Zoom set up through Canvas. And if anybody's interested in talking about any of these disorders in more detail, shoot me an email and we'll set up a Zoom conference and then you can ask questions or we can talk about it in a lot more detail. Now, PTSD develops after a traumatic event. All right, and this is a little bit weird because for whatever reason, some people will develop PTSD and others will not. So you can have two individuals go through the same traumatic event, witness the same event, and one person develops PTSD, and then that can become a lifelong struggle for them. And other people actually go through something called post traumatic growth, where they become a much more resilient person afterwards. So there are some individual differences as to how PTSD and how traumatic events affect each of us. But everybody who has developed PTSD is in response to a traumatic event. Now, a traumatic event, most of the time, it's defined as an event where you perceive your life to be in danger or somebody else's life to be in danger. And so a person goes through a traumatic event like that. develop PTSD, the symptoms, there's a bunch of different symptoms, but the four big ones are recurring memories of the event. So the individual will just have these memories that pop up, and it's not like they want to remember the event happening. These are really intrusive memories that just kind of pop into the person's head of that event, and they can be very vivid. Same thing with the nightmares, recurring nightmares, where they're just reliving those events very vividly. Flashbacks, in the sense that they're again, when they're awake, they relive that event in the sense that they get flashbacks to the emotions that they felt, or the things that their nervous system was going through, that whole fight or flight, that really intensive fight or flight that their nervous system was going through. They get all of those feelings back, all of those emotions. And eventually this kind of accumulates into a persistent avoidance of really just avoiding anything that can trigger any of these memories, any of these flashbacks, where again, some people, it gets so severe that they just self isolate, and it's a horrible condition. Getting out of bed in the morning can become a really difficult thing to do for somebody with severe PTSD, especially if it's left untreated. Unfortunately, when we're talking about PTSD, most of the time we're talking about veterans, because again, military personnel, they generally suffer from PTSD at much higher rates, but they're not the only ones. So um, anybody can develop PTSD in response to a traumatic event. So that could be something like having a severe car accident that can make it really hard to get back into driving. Sexual assault victims, rape victims suffer from PTSD. People who've been abused as children suffer from PTSD, which kind of leads me into this next slide, and the biological effects that PTSD and just really trauma can have on the brain and brain development. So, this is something called complex trauma, which is trauma that happens over the period of a long time. So, maybe over a period of a couple of months, over a period over several years. And at the very top here in this picture, what you have is two brain scans, two completely different individuals. So on the left side, there's a brain scan of a healthy brain, a brain that has not gone through any trauma or abuse. Then on the right side is a brain scan of an individual who went through, looks like some pretty severe abuse. And what we know about PTSD, and this is no different if it's complex trauma or it's just one episode of trauma, is that there are changes that happen structurally in the brain. There's stress hormones that are released that do damage. There's certain areas in the brain that is completely shut off. Now, the amount of damage it really depends on the severity of the trauma, how long the trauma takes place, and then individual differences. Like I said, some people are just a lot more resilient, um, but we know that PTSD, trauma, going through trauma causes damage. And one of the things that really historically that opened a lot of psychologists and neurologists' eyes to this was the Romanian orphan crisis. Now, I want to say this was in the 80s. I'm not, or 90s. I'm not entirely sure, but a lot of people here in the United States and throughout Western Europe were adopting a lot of these Romanian orphans who were put into these orphanages. There's a little picture here in the bottom right, in just in horrible conditions. And there were people there that were feeding them and trying to help them, but there was just so many orphans that there really wasn't enough. And you can Google some of these pictures. They're horrible. So I try to choose one of the mildest ones, but there's some really intense, horrible pictures of these situations that these kids kind of grew up in. And so a lot of people adopted these kids and brought them here to the United States. And what ended up happening is that um, a lot of these kids, even though they were adopted into these better homes and these better situations and loving families, still ended up having a lot of issues later on in life. So, either behavioral issues, either where they were really aggressive, or even just cognitive disabilities where they just weren't, they just cognitively couldn't, they just didn't match up with their peers. And so this prompted a lot of research, and people were interested in like, why was this happening? Because yeah, so these kids grew up here, they grew up in a normal healthy home. And so what ended up happening with this research and what we now know is that trauma and early childhood trauma specifically has a huge effect on brain development. And you can kind of see this in this bottom left corner picture here of the two brains. So these are two 3-year-old children, different individuals. Again, on the left side is a normal 3-year-old child's brain. On the right side is a brain that went through some extreme neglect, probably some severe abuse as well. You can just see the difference in size. You also see there's a lot more dark spots on the brain in the right side, so not just in the middle, but even if you just look at the outside of the brain, a lot more dark crevices. And what black spots mean is that there's no gray matter there. That means that those areas of the brain either didn't develop or they were damaged and those neurons died out. And we know that that's true for trauma, that trauma stunts brain development. And even if the trauma happens in the first 3 years of life, and then that person goes through a normal development and goes through a healthy environment, a lot of what's lost developmentally, there's just no way of making that up. And this is one of those reasons why child neglect and like just childhood abuse is so severe, because it can have really long lasting impact and really damages brain development. Now, like I said, I'm probably not doing this topic any justice, but if you are interested in this, like I said, I've got the Zoom thing set up on Canvas, and just shoot me an email and we can discuss any of this stuff in a lot more detail. All right, moving on to our last anxiety disorder. It's obsessive compulsive disorder, or OCD. Now, OCD, or obsessive compulsive disorder, is made up of two components. There's your obsessions and then your compulsions. Obsessions are a little bit different. So these are not like obsessions that we kind of use the word obsession, or this person's obsessed in the daily sense. So like it's not my obsession with Taylor Swift, for example. Obsessions in this sense are intrusive, repetitive, and unwanted thoughts. All right. So intrusive, repetitive, and unwanted thoughts, thoughts that cause an individual some anxiety. So this, again, intrusive means that the person's not really thinking about it. They just kind of pop into this person's head and cause them a great deal of anxiety. And I'll give you guys some examples of this. Now, the only way somebody can get rid of that anxiety is by doing one of the compulsions. And so compulsions are repetitive behaviors or mental acts that an individual feels driven to perform, and they feel driven to perform this because of that anxiety, and this then relieves that anxiety. So, for instance, a fairly common one is like the hand washing OCD, where an individual feels like their hands are dirty, their hands have bacteria on them, and so that thought causes them some anxiety, like, oh my god, my hands feel dirty, there's dirt, there's bacteria, they're crawling with things. And the only way they can get rid of that anxiety is by going and performing the compulsion, which is washing their hands. And then once they wash their hands, that anxiety goes away up until the next time that obsession comes up, right? So that it depends on how severe it is. It could be a couple of hours, it could be a couple of minutes. Some people feel driven to do this every 15 minutes. So every 15 minutes, they're hit with this thought, oh my God, my hands are dirty. They're dirty. There's stuff crawling on them. I'm going to get sick. And then the only way they can get rid of that anxiety is by performing their compulsion of washing their hands. Now, obsessions and compulsions don't always need to make sense. So I had a client once where her obsession was, anytime she drove somewhere and parked, she couldn't get out of the car because she felt like if she got out of the car, either while she was crossing the street or something, somebody else was going to hit her. So she felt like she couldn't safely get out of her car. So she would park, all this anxiety would happen, which would stop her from getting out. She developed a compulsion. It doesn't really necessarily make sense, but her compulsion was she had to add up all the different license plate numbers that she could see in that parking lot. So every license plate that she could see, she would have to add up all the numbers that she saw. And once she did that, then she felt good, anxiety went away, and she could get out of her car. Now, this is pretty debilitating because what ended up happening was that if a car left or another car pulled in, she would just have to start all over again. And so she was missing important stuff. Like she was missing finals exams, she was missing classes, she was missing work. And so this became really debilitating for her. So again, they don't always need to make sense. But that's really what obsessive compulsive disorder is all about. All right, moving on to our mood disorders, and we're going to start out with major depressive disorder, or just commonly known as major depression, or what we generally think of when we're thinking about somebody who's depressed. Now, major depression has a lot of symptoms, a lot more than are listed here, and we're not even going to go through these four. The main thing to remember about major depression is that it's an overwhelming feeling of worthlessness and hopelessness. So, people who struggle with this or suffer from this disorder, um, there's this overwhelming feeling that they're just worthless, that nothing good should ever happen to them, nothing good can happen to them. They're just worthless. And then the other part of this is the feeling of hopelessness, that this situation is never going to change. This is always going to be the same thing. So it's a really horrible condition, a horrible way of having to feel. um, it gets to the point where people with this disorder will lose any kinds of enjoyment. So even if they had hobbies before, or things that they really enjoyed, or people that they really love to be around, um, they get to a point where they no longer want to do any of that. They lose interest. They lose interest in the people. They don't feel like they want to be around or do things that they really enjoyed. And that's really the hallmark. And that's really all you really need for this next exam, or as far as being able to identify major depression, is understand it's this extreme feeling of worthlessness and hopelessness, coupled with a loss of interest in things that they really enjoyed. And that's all we're really going to do as far as covering depression. So the next couple of disorders we're going to talk about, they're all part of the mood disorder family, and they're all a different variation of depression. The first one being seasonal affective disorder, or SAD. This is major depressive mood during the fall and winter months, that then goes away during the spring and summer. So, for whatever reason, when it's fall and winter, people who have seasonal affective disorder will meet criteria for major depression. So, they'll be depressed. Um, and then, as soon as spring and summer rolls around, that depression goes away and they're back to feeling normal, and they're just going about their daily life. So, it's a seasonal thing. Um, some people theorize that it's because during the winter months it's gloomy outside, it's rainy, people don't spend a lot of time outside, and that might be the cause. And then as soon as the weather gets better during the spring and summer, there's more sunshine, people are outside more, and that might be the reason for SAD, or SAD, or seasonal affective disorder. The next one is something called persistent depressive disorder, which is a very chronic, low grade depressive feeling. It's not severe enough to be major depressive disorder. I always tell my students a good way of conceptualizing this is if you just think about Eeyore from Winnie the Pooh. That's uh, probably one of the best ways to conceptualize what persistent depression looks like. So um, Eeyore was still somebody, he would still go out with, Winnie the Pooh and everybody else. They would go on adventures, and he would still participate in all of that stuff, but he was always kind of down, right? He was always kind of like, all right, whatever, I'll go. This sucks, right? But so it's not bad enough for individuals to isolate themselves. So people with persistent depression, generally they'll still go out, they'll have relationships, they'll perform at work, they can, it's not debilitating, but they just always seem kind of down, and that's really what persistent depressive disorder is. Up next is bipolar disorder. This is one that a lot of people kind of have a misconception about. So I hear this all the time. I hear people say, "Oh, I'm bipolar," and what they mean is that they have extreme mood swings to the point where I can be happy 1 second and then be really, really angry the next, and then be really, really sad, and then go back to being happy. And that's not really what bipolar means. Um, Bipolar, definitely it is a mood swing, but it's a disorder. It's a cycling disorder, and there's only really two moods that people cycle through, and that's depression, and the other one being mania. So they'll be depressed. They'll meet criteria for major depression. They'll be depressed for a couple of months, and then they'll cycle. They'll have a couple of days, maybe a week, maybe 2 weeks, where they're manic or they're in their mania, and once that's over with, they're back cycling into depression for a couple of months, and then back into mania. And so, just to give you a time frame for conceptualization. So somebody with bipolar disorder might be depressed for 2 to 3 months, then have a week of mania, and then go back to 2 to 3 months of depression, and then go back into mania. Now that's not that time frame. It's not always like that, but just to give you an idea of how the cycle kind of works. On this next slide, we'll see the distinction. So there are two types of bipolar disorder. It's bipolar 1 and bipolar 2. And the thing that really sets them apart is how severe the manic episode is. So in bipolar 1, it's full-blown mania. In bipolar 2 disorder, it's something called hypomania, where it's a little bit less. It's not as severe. And what mania is individuals who are manic, they feel very euphoric, they feel a blast of energy. It's not uncommon for people with mania not to have to sleep for a couple of days and just still be energized. They'll feel really good, really happy. They'll have flights of ideas, like every idea sounds good. A lot of impulsive behavior during mania, so a lot of things that they normally wouldn't do, like substance abuse, extreme substance abuse, have multiple sexual partners in a span of a couple of days. Some people have completely got up, left, and like traveled to different countries with intentions of living there. And it's all fine and good until that mania runs out, and then they're back to being depressed. And on the right side of the slide, there's a picture of where they caught um, they've done these brain scan studies where they actually were able to catch a person's brain during this transition. So the top row of the two brains, that's the person's depressed, and then those two middle brains where everything is lighting up, that's when this person's in their manic episode. So all of a sudden the whole brain is lit up. There's all this activity, all this energy, all this euphoria, and then a couple of days later, the next scan, the person fell back into depression. And that's really what bipolar is. So it's not extreme mood swings to where like in 15 minutes I can be happy, sad, and then crying and angry and raging. It's a lot more subtle. It takes a lot longer than that. So it's depression for a couple of months, then mania for a couple of days, and then back to depression for a couple of months. As far as the eating disorders go, we're not going to spend a lot of time on them. I'm just going to run through them really quickly and just briefly tell you what you need to know about them. So anorexia nervosa, you can kind of think of this as self-starvation. So individuals who suffer from this disorder, they won't eat. I mean, and if they do, it's very, very tiny, minimal portions. Anorexia nervosa, these are the people generally who suffer from this. It's a dangerous disorder, so they can actually die. As far as the eating disorders go, this is probably the most dangerous because they get to points where they're at very unhealthy weights. So, like, talk about 90, 80, 70 pounds, to the point where if you look up pictures of anybody suffering with anorexia, you'll see that it's skin and bones. They get to points where they're just at unhealthy weight, and they can have organ failure and then die from that. And it all stems from a really unrealistic self-image and a fear of either gaining weight or becoming too fat. And so that's really what it is. And so they'll just starve themselves basically. The next one is bulimia. And bulimia nervosa, individuals with this disorder, they'll actually eat, and they'll eat large amounts of food. But the problem is that they'll have some kind of a purging behavior afterwards. So what that means is they'll either throw up after they eat, or they'll abuse laxatives. So they'll take a bunch of laxatives after they eat just to get rid of that. Or they can do something like spending crazy amounts of hours in the gym just trying to work all of that stuff out. So they'll actually eat, but then they'll feel guilty. And again, there's this fear of gaining weight. And so then they'll purge. So they'll either go to the bathroom, throw up, use laxatives to get all of that stuff out of their system, or then just spend a lot of time exercising. The last one, which is a fairly newer one, is something called binge eating disorder. And this is very similar to bulimia, where people will binge eat. So they'll eat a bunch of food in one sitting, usually a lot of high carb foods, a lot of candies, a lot of cake type of pastry type things, but they'll eat a bunch in one sitting, but they don't follow it up with a purging behavior. So these individuals don't follow it up with throwing up or anything like that. They eat a bunch, they binge eat in one sitting, and then that's it. Now there are some health effects here too. So these individuals generally end up being very obese and also again unhealthy and can eventually die. But that's really all we're going to do as far as the eating disorders go, and we're going to move into our personality disorders. Personality disorders are organized into three clusters, and that be clusters A, B, and C. And they're clustered into this based on some commonalities that they share. So these personalities tend to be similar. The first thing we're going to move into is look at cluster A, which are odd, bizarre, or eccentric personalities. And there's three personality disorders that go into that. There's your paranoid, schizoid, and schizotypal personality disorder. Paranoid is actually a fairly self-explanatory one. If you just think about what it means to be paranoid, if you've ever been paranoid in your life, think about how you felt and think about how you behaved and acted. That's what paranoid personality disorder is like. However, they're paranoid constantly all of the time. So these people will be paranoid. Like if somebody says hi to them, like they're wondering why did that person say hi to me? Or why is this person being nice to me? They're probably up to something, right? They walk into a room and hear people talking. They're like, oh, those people are talking about me. I got to figure out what it is. So just constantly paranoid about everything. Schizoid and schizotypal. Some people get these mixed up because they sound very similar, but there's a very easy way to remember how to distinguish between them. If you just look at the last letter of each word. So if you see schizoid and you remember that, okay, it ends in a D, and you can remember that that D stands for distancing, you'll be fine. So schizoid, remember it ends with a D, that stands for distancing. So schizoid is social distancing. These people, not what we're doing right now, but these people distance themselves socially. They don't want to have any social interactions. So they don't want to have friends. They don't want to talk to anybody. They don't want to interact with anyone. They don't even want to have romantic relationships. These people don't even want to have sex with other people. Like they don't want to do anything social at all. If it was up to them, they would be on their own, stuck somewhere in a room or a remote island where they'd never have to interact with anybody. That's schizoid, social distancing, ends with that D. Um, Schizotypal ends with an L. If you can remember that that L stands for limitation, you'll be fine. So schizotypal is social limitation. These people would actually love to have relationships and would love to have friends, but because their social skills are limited, they come off as kind of odd, and eventually most people just kind of stay away from them. They come off as a little bit awkward. Their social skills are a little bit off. Like they just come off as a little bit weird. And so even though they would love to pursue relationships and have friends, and they go out and they try to meet people and interact with them, everybody's just kind of a little bit weirded out by them, and then they kind of stay away. All right. Cluster B deals with dramatic and erratic personalities, and there's four there. The first one being narcissistic personality disorder. This one, again, is probably fairly self explanatory. If you just think about what it means to be a narcissist, think about that, and that's your narcissistic personality disorder. So these are people who are very self absorbed, um, think they're just God's gift to the world, that they're the greatest thing ever. Everything, they know everything. Nobody else knows anything. They're always right. Everybody's always wrong. That's a narcissistic personality. Histrionic personality disorder. These are people who generally have to be the center of attention. Um, if they're not the center of attention, they start to feel really anxious. They get really upset. They always have to be the center of attention. If for whatever reason the spotlight moves away from them, they'll do something to make sure that that spotlight comes back on them. So it can be something really dramatic. They'll even do something really embarrassing and then point out, "Oh, did you see how I did that? Wasn't that embarrassing of me?" Just so that they can kind of get that that spotlight back. So um, sometimes they'll just be really big on gossip, like they have all of the all the new gossip. They're in the know, just to make sure that they have that attention. It's not unheard of that they'll dress really provocatively, or even they'll interact with people in very flirtatious ways just because they want that attention. That's your histrionic. It's a kind of drama queen on steroids, just attention seeker, needs to be the center of attention all the time. Borderline personality disorder is a very complex disorder. We're not going to get into it into too much details. Um, just for the purposes of this class and being able to identify it, just know that an easy way to spot borderline personality disorder is if this individual has a very erratic relationship. So borderline personality disorder comes with very high and low emotions. And so this is the one where most people say this person's bipolar. This is what they're actually talking about. So these people can be very happy, very friendly, very nice 1 second, and the next second they're angry or they're upset, they're sad. So this is like, I love you, you're great, and then 2 minutes later, I hate you, you're the worst person in the world. So this comes with very erratic relationships because it's very high and very low emotions. Um, the last one on this list is antisocial personality disorder, and this is what we used to actually call sociopaths. It's now termed antisocial. Now it's a little bit misleading because if you think about what antisocial means, you're probably thinking of somebody who doesn't like to socialize. But that's not actually true. Antisocial people are generally pretty charming. They're actually pretty good at socializing. But what this is that these people can do really horrible things. They can do very manipulative things, do very bad things to others, and just not feel guilty about it. So they just don't feel guilty. Now, this doesn't have to be serial killers, but most serial killers probably have some antisocial personality where they can murder entire families and then not feel bad about it. But it doesn't have to go that far. It could just be manipulation. It could be like con artists, people who con people out of their like life fortune and then just not feel bad about it, or just do some mean, horrible things and then just not feel bad. That would be your antisocial personality disorder. Cluster C deals with anxious and fearful personalities. Avoidant personality disorders. So these are people who avoid relationships, especially romantic relationships, out of the fear that they'll be hurt or be abandoned. So I'm not even going to give you a chance to abandon me because I'm not even going to give you a chance to be in a relationship. Dependent personality disorder, on the other hand, is the opposite. So these are people who get into relationships out of the fear that they'll be alone or isolated. So these people will jump into any relationship, anybody that gives them any type of attention. So if you've ever, found yourself in this situation, somebody asks you for the time, you tell them the time, and now you find yourself in a relationship with that person. That's that dependent. They come off as very clingy. You can't, even if you're in a relationship with them, we can't do our separate things. So as soon as you say, I'm going to go out with my friends tonight, you do your own thing, they'll come back and say, oh, why don't you love me anymore? Or where are you going? I'm just going down to the mailbox. Oh, okay, I'm coming with you. Like that kind of very dependent. Um, Unfortunately, people who have this disorder tend to find themselves in very abusive relationships and then don't get out of them, because even though this is a horrible relationship for me, it's still better than not being in a relationship at all. So that's the unfortunate thing with that. Obsessive compulsive personality disorder. These are people who are very meticulous. So they're perfectionists. Everything has to go to plan. So people who keep schedules and run tight schedules, and as soon as anything deviates from that, they lose control or they lose their temper. That's what obsessive compulsive personality is about. It's all about control, making sure they're in control of everything. So they keep schedules. This is when I wake up. This is when I shower. This is when I go to work. This is when I eat. They'll even have like time, like this is when we can have sex. It's very controlled, and as soon as something deviates from their plan or their schedule, they that anxiety just takes over and they lose it. So that's your obsessive compulsive personality. Perfectionists, everything has to go to schedule, everything has to go as planned. And that's pretty much it for the personality disorders. Like, again, like I said, if you have any questions about any of these, shoot me an email, or we can even get on Zoom and All right, coming up on our last two disorders for this chapter. This one here, dissociative identity disorder, might be the most controversial out of all of them. So DID is what we used to call multiple personalities, and it involves extensive memory disruptions along with the presence of two or more distinct identities or personalities. So if you ever saw or watched that movie Split, that was a pretty good depiction of what DID might look like. The reason why it's such a controversial disorder is because not everybody agrees that this is actually a real thing. So there's some people out there that believe this is not a real disorder, that it might be some other form, a worse form of post-traumatic stress, for example, or some people say that these people are just making this up, that this is not real. Then there's other people who say, no, this is definitely a real thing. So it's pretty controversial in that sense. Um, but again, that movie Split was probably a pretty good depiction of this, where it was the same individual, but he had multiple personalities to go along with his personality. So one of his multiple personalities was, I believe, like a young boy, like a child. One was a woman. One was a homosexual male. Another one I want to say was like a more aggressive person. So there's all these multiple personalities within that same person, and kind of this is where the memory disruptions come from. So theoretically, when another personality is in charge or taken over or in control, you would be unconscious and you wouldn't really know what was going on. You wouldn't know what the other personalities are doing. But again, very controversial, and we're not going to spend a lot of time on this one. The next one being schizophrenia, and again, this is a big disorder. I'm probably not going to do it much justice for this course. We're just going to go through some of the symptoms. So, the symptoms of schizophrenia: delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and then negative, also positive symptoms, but we'll get on to those on a future slide. As far as delusions of schizophrenic individuals or people who suffer from schizophrenia, there's a couple of them, four that we're going to go through. So, delusions are false beliefs. The first one being delusions of reference. So, some people with schizophrenia have delusions of reference, and these are delusions, these are beliefs that things are happening in the environment because of them. So they're referencing things that are happening in the environment and attributing them to themselves. So, for example, you could be talking to an individual, and let's say a car drives by and they're playing a radio really loud. And this person will turn around and say, "Hey, did you just hear that car playing that song? They're playing that song for me." Or they're watching the news and they'll say, oh, this newscaster is talking in code to me. Or this, they're watching a movie and this movie could have been made 40 years ago before they were even born, and they'll say, the director made that movie because they knew I was going to watch it right now, and there's a secret message there. That's delusions of reference. They're referencing things that are happening in the environment and they're attributing them to themselves. Delusions of grandeur, these are delusions where they basically believe that they're something important or special. So this little picture I have here of this guy looking in the mirror and he sees himself as Superman. That's kind of a delusion of grandeur. A lot of times these delusions come off as with people with schizophrenia in particular, is where there's some kind of an impending doom that the world's going to end or be destroyed, and they're the only person that can save the world from destruction. Either that they have some information that they need to get to the government that can save the world, or a lot of times this manifests itself in the sense that they believe that they're talking to God, and so they say they're the reincarnation of Jesus Christ, and they're here to save humanity and whatnot. So that's delusions of grandeur. Delusions of persecution is this delusion where they feel like they're being persecuted. This oftentimes you'll see this a lot with like the government's after me, everybody's a spy. They don't trust anybody. Everyone's out to get them. Everyone's trying to harm them. This is one of the tough ones with schizophrenia. It's delusions of persecution. People They won't take their medication because they feel everybody's out to harm them. Like, this isn't going to help me. This is actually poison. Then the last one is delusions of being controlled, and this is exactly what it sounds like. They feel like they're being controlled. Either somebody had implanted a chip in them and is controlling them with a remote control, or they're not doing their own. They're not responsible for their own behavior. Somebody's controlling them. There's an example of this a couple of years ago. There's a guy from Alaska who flew to Florida and then shot up the airport down there in Florida. And when they arrested him and caught him, he basically said is he went to the FBI a couple of months ago and they implanted him with a chip and they were actually controlling his behavior. So that's kind of that delusion. As far as hallucinations go, auditory hallucinations are probably the most common with in regards with schizophrenia. So most people who suffer from schizophrenia deal with auditory hallucinations, meaning that they hear things that aren't really there. I know in a lot of movies, the visual hallucinations get played up that people with schizophrenia will like they'll see things that aren't there. That it's true, but that's actually less common than the auditory. Like more common is that you hear things that aren't really there. Visual hallucinations, it's still a thing with some people with schizophrenia, but it's a lot less common. I want to say it's something around 23 to 25% of people with schizophrenia actually have visual hallucinations, and they differ. So it could be just shadows and little shapes to really full-blown hallucinations of like individuals, and you, they believe they're actually seeing people. Tactile hallucinations are that means feeling and touching things. So they might be touching a surface that's really soft, but it feels like it's sharp and hurting them and prickly. This also goes into like people who feel like their skin is crawling with insects or stuff's crawling on them. That's tactile. Smell and taste hallucinations, very rare, but that's smelling things and tasting things that aren't actually in the environment. As far as positive and negative symptoms of schizophrenia go, so this has nothing to do with good or bad. So positive symptoms don't mean they're good, negative symptoms don't mean they're bad. Positive symptoms are things that you don't expect to be there, but they're there. So, for example, hallucinations, that'd be a positive symptom because you're seeing or hearing something that's not actually there. So, again, you're adding something into the environment that you don't expect to be there. Negative symptoms, on the other hand, you're taking something away that you would expect. So there's flattened affect, which is basically showing no emotions, where you would expect there to be emotion. So somebody with flat affect could tell you a story of something really horrible that has just happened to them. And you would expect this person to be kind of sad about that or feel bad about it. And they're just like kind of meh, whatever. They're just telling it to you very monotoned, or they tell you something really funny and you'd expect them to laugh, but again, they're just very, very monotone about it. Reduced speech is something. So you can, somebody with schizophrenia might have something called alogia, where you can ask them a question and they just don't respond. They have the inability to respond. That's reduced speech. So you would expect them to be able to talk and respond to your question, but they don't. So that's a negative symptom. And then lack of initiative or motivation. That's another one where you would expect them. So you can, somebody with schizophrenia might be sitting there and you can pinch them and you would expect them to move their arm, but they just keep their arm there because they have lack of initiative, lack of motivation. Again, that's a negative symptom. All right. Again, if you have any questions about any of this stuff, just shoot me an email and we can discuss it further. The last thing, unfortunately, when we do talk about psychological disorders, and you guys know how much I like to end on a positive note. Um, we're gonna have to talk about suicide here, and really the only thing related to suicide that we're gonna cover in this class for the disorders is really the gender difference. And the gender difference being that women attempt suicide at much higher rates than men do, and I think this is about a 4 or 3 to 1 ratio. So for every man that attempts suicide, there's 3 or 4 women that have attempted suicide. So at much higher ratios, so women will attempt it at much higher ratios than men. However, when we're looking at the statistics of who actually dies by suicide, men this ratio kind of flips, and men actually die at much higher rates of suicide than women do. So it's a weird thing, because you would expect if women are primarily the ones who are attempting suicide, you would also expect them to be the ones who are dying of suicide, but that's not really what we're seeing. And one of the explanations for this flip in the statistics is the method. So when women are attempting suicide, generally it's by either cutting the wrist or by trying to overdose on medication, which are less lethal, right? So, I mean, it's never a good thing, but if somebody walks in at the right time, you can put pressure on the wound, get them help, or even get them to the hospital, have their stomach pumped, or it's a lot less lethal than what men will do. Men generally, if they're going to commit suicide, they're either going to use a firearm, shoot themselves, or hang themselves, and those are things that are very hard to reverse. A lot of times with hangings, like you break the neck and they die that way, or it doesn't take too long to strangle. And if you shoot yourself, regardless of when somebody walks in, there's nothing you can do to kind of reverse that. So that's the reason for these statistics and why that ratio flips. And that's pretty much it for this chapter. So, again, like I said, if you have any questions, try to match this information up with the study guide. If you're not getting something or you're not sure about, the study guide or this worksheet that's up on Canvas as well, just shoot me an email. We can either hash it out through email, or if you want, we can get into a Zoom conference and discuss it that way. All right. And then next week, we'll be covering treatments and the different treatment modalities for most of these disorders.